So this is a model of a knee, and you can see this is the front of the knee, this is the side of the knee, and this is the back of the knee. This is the thigh bone, which is we call the femur, and this is the shin bone, which is called the tibia. And then the knee joint is basically formed by a confluence of the thigh bone and the shin bone. And normally we have cartilage in between the two parts of the bone, which allow a frictionless, smooth gliding motion of the knee. But when the cartilage wears out and we begin to get bone on bone, that's what causes the inflammation, the pain, and the limitation of motion. So usually when a patient comes to me with, with knee pain, as a surgeon, I don't just jump into surgery. I think that it's important for us to explore the full spectrum of care, and that includes all the non-surgical options. And knee replacement is really what I say the last chance salon, the last option in the hierarchy of treatment. And that is when somebody has exhausted all other treatments and it hasn't worked, and they have very severe bone-on-bone osteoarthritis or other type of arthritis that has led to a position of severe pain, severe limitation in their mobility, in their ability to function, and that's when we would consider this kind of replacement surgery, because in that group of patients, this can be life-changing, literally life-changing, because suddenly they feel that they're able to move and walk and enjoy their everyday activity without the constant pain and the suffering. So this here is the muscle in the front of the thigh, which kind of joins in to form the kneecap, and then that forms the tendon that attaches. So when we have to do a knee replacement, we have to go around it. So we have to cut that open, and if I can demonstrate the inside, we move that out of the way, and then we expose the thigh bone, and essentially we have to make several cuts to the thigh bone and prepare the bone. And then we work on the shin bone, and you can see that we have to cut the top end and we have to shape it to really receive the implant. We also have to tension the surrounding ligaments on either side and front and back, so that you have a relatively well-balanced knee that works through the full range of motion that you require for day-to-day activity and function. Okay, and so these implants are then inserted into the tibia, okay, and then we put a component on top of that, and then the femoral component likewise, and there are different metal alloys and components the different implants are made of, are then put into the thigh bone, and then they're put back together. And sometimes we will also have to replace or resurface the kneecap. Then we put everything back together, it's all put back together, and essentially there is your knee replacement with the implant in. The latest advances is with robotic technology is that it is able to give us more biomechanical data on the knee. So everybody's knee can be a little different. Even your right knee can be a little different from your left knee. So the robot augments those specific, unique, both anatomical features and also what we call biomechanical features, meaning the tension in the ligaments, the tension in the tissues. And by honing into that, what we're aiming for is to achieve a more natural feeling knee that is more natural to you, as opposed to a more generic, standardized procedure. It is customizing it and making it more specific to your individual knee. And the advantages of that should mean quicker recovery, earlier function, and ultimately with the goal to achieving higher levels of function. So after knee replacement surgery, it is very important to undergo rehabilitation, because what is important is to ensure that we work the muscles and tendons and ligaments to regain the function as the healing process progresses. And then the next phase of that is to strengthen the muscles and ligaments and tendons to be able to regain that function.